These are the usual infections that are seen: bacterial infection, viruses, fungal, parasites are all implicated. They have their free day because baby maternally acquired antibody has been depleted and the baby cannot produce his own antibody or her own antibody. So we'll be talking about the inherited immunodeficiency now, one after the other. You have the B cell related disease that account for more than half, and the first one is S-linked gamma globulinemia or Brutin, the common variable immunodeficiency. You have the isolated IgA deficiency, and you have the T cell related, okay, primary immunodeficiency. Digeorge syndrome is the first one we talk about, and then which is thymic hypoplasia, the thymus in the anterior mediastinum becomes hypoplastic. And then we talk about Wiskott-Aldrich syndrome, and then the combined B and T. It can also have a deficiency of B and deficiency of T. You have the severe combined immunodeficiency disease. So, and then reticular agenesis is also a combination of B and T. Okay. So we also have phagocytic deficiency. We talked about phagocytes last time. Then there could be one deficiency of the enzymes. You cannot phagocytose bacteria or fungi. So phagocytic defects are characterized by impaired ability to phagocytic cells, such as the monocyte, the macrophages, granulocytes, such as neutrophils and eosinophils to kill, and this can also account for some degree of immunodeficiency. Example is this chronic granulomatous disease or leukocyte adhesion deficiency type 1. These are the names. The phagocytes are weak, and for one reason, maybe they lack enzymes, lack granules, they come in contact with pathogens like bacteria, and they cannot phagocytose them. So that can cause, apart from the deficiency of B and T that we have listed. So the S-linked gamma globulinemia of bloating is that there is a mutation that is affecting maturation of B cells. There is a, it is characterized by failure of the B cells to mature the pro-B and the pre-B, which are the precursors of B. They cannot mature into B cells. Okay, so there is a block in the differentiation between heavy chain and light chain due to mutations in the. So if you don't have B cells, you cannot have antibodies, you cannot have immunoglobulins. So because, but you have pro B, they are immature B, you have pre B, they are immature B, but they cannot move on to B cells because of this mutation in the cytoplasmic enzyme tyrosine kinase. So called B cell tyrosine kinase, BTK, is mutated. So the enzyme is responsible for the maturation of the B, pro B and pre B into B cells. So seen entirely because it's X-linked in males, but few sporadic cases in females. Okay, so it's possible to have it. That's why it's S-linked. Anything S-linked is, but when can you see female carrying infection as a result of S-linked? What condition can make a female, be S-linked, uh, has S-linked disease like hemophilia. Hemophilia is S-linked. This is S-linked too. What will make a female to be to have S-linked disease? What condition? What condition will make Turner syndrome? Turner syndrome. Turner is XO. So if the X that is affected is inherited, a male is XY and the female is XX. So if the affected X is from the father and there's O, you know about the chromosome O, XO in Turner's. Okay, so it have can affect females. Any X-linked, just like hemophilia too, can be seen in female, despite the fact it's X-linked. So only sporadic cases. So because there is no B cells and there cannot be plasma cells, if there is no plasma cells, there cannot be immunoglobulins. And then the maternally acquired antibody would have been depleted. Hey, seen about 6 months of age when maternally acquired immunoglobulins are depleted. So usually they are bombarded with various infections, so respiratory tract infections like acute and chronic pharyngitis, sinusitis, otitis media, bronchitis, and pneumonia. Or infection is almost always due to encapsulated organisms such as H. influenza, strep pneumo, staph aureus, because of lack of antibodies to opsonize them. Okay. So they are bombarded with various forms of infection. Viral infections are not left behind, like echovirus, poliovirus, Coxsackie virus are also common pathogens. Okay, but protozoans infections are also involved, like the Giardia lamblia is implicated. So the child is exposed to a lot of infections. So B cells are absent or markedly decreased in circulation and serum levels of all the kinds of immunoglobulins. So it affects all the levels of immunoglobulin. Treatment is with intravenous immunoglobulin. There is no, except they want to do a transplant. Transplant, stem cell transplants can cure the disease, but apart from that, you replace what is missing. Intravenous immunoglobulin. You have intravenous immunoglobulin. In this one, common variable immunodeficiency, the B cells are there, but they cannot form plasma cells. It's still the same. If you have B cells and then you cannot have plasma cells, you cannot have antibodies. So this presentation will be similar. But the X-linked gamma globulinemia is that you cannot even have B cells as a result of the mutation of the tyrosine kinase, gluten tyrosine kinase, the BTK. So if you cannot have B cells, you cannot have plasma cells. But in common variable immunodeficiency, there is no mutation of the enzyme, so you can have B cells, but they cannot produce plasma cells. So and then if you cannot produce plasma cells, you cannot have, so it's hypoglobulinemia. It's seen in all patients, generally affecting the antibody classes, but sometimes only IgG. The most patients have normal or near normal numbers of B cells in the blood and lymphoid tissue, but the B cells are not, however, able to differentiate into plasma cells. So the clinical features are due to antibody deficiency, hence they resemble those of the S-linked, the gamma globulinemia, but this is not S-linked. So it's seen in both male and female. Okay, so both sexes are equally affected. So there is this next one, isolated IgA. From that name, it just, there's adequate amount of IgG, there's adequate amount of IgG, IgM and IgE are adequate, but just the IgA. So it's a rare disease, but you just have some people have deficiency of IgA. seen in 1 in 600 individuals of European descent in the US, but rarely seen in blacks and Asians. Just the IgA that is singled out are very common among Arabs and Spanish. There is a low level of both serum and secreting IgA, so it's called isolated IgA deficiency. Most individuals with this condition are completely asymptomatic because the IgG is there to protect. IgM, first responder, is available and adequate. IgD is adequate. IgA is deficient. Okay, so but if it can, they can be symptomatic too. IgA being the major immunoglobulin in external secretions, mucosal defenses are weakened, and infections occur in the respiratory GIT because you have other layers of defense, the cilia that we talked about, the chemicals, the salivary glands secrete chemicals, the acid in the stomach can also be called to play when you have infections. Okay, the skin, the stratifier, we discussed that last time, but IgA is also important. So occasionally you could have infection affecting the respiratory GIT, and so symptomatic patient with recurrent pulmonary infections and diarrhea.
So,
So the basic difference in IgA deficiency is in the differentiation of the naive B to IgA producing cells. Just B cells cannot differentiate, but can differentiate into IgG, IgD, IgM, IgE. So when transfused blood containing normal IgA, some of these patients, because they lack IgA, they can develop IgA in the blood, can act as antigen, and then they can develop antibody to the IgA, and then they will react with anaphylaxis. So some of these patients develop severe, even fatal anaphylactic reaction because the IgA behaves like a foreign antigen. They lack IgA, and then you are giving them blood of someone with IgA. The body of the recipient will consider the IgA as foreign and then develop antibodies to that IgA. Antibody, because IgA is antibody itself, is antibody itself. So it's like an antibody to an antibody. So and then there will be anaphylaxis. So patient with isolated IgA deficiency should be given washed. So how do you go about that? So you can identify isolated IgA. So you need to wash the blood plasma, and then before you transfuse, if you wash it, then you are going to be depleting the IgA content in the plasma. So how do you wash? With detergent. You wash with normal saline. You wash the blood with normal saline and decant. So most of the time you even give me Paxel. You give Paxel and then wash the Paxel. So you don't give plasma because plasma, the IgA is dissolved in the plasma. So if you give IgA containing blood to isolated IgA deficient patients, the patient will see the IgA in the blood as foreign and then produce an antibody against the IgA, and then it will cause anaphylaxis. The patient can die. So that's the importance of this isolated IgA. So you also have the T cell related thymic hypoplasia. The thymus is hypoplastic and results from failure of development of the third and the fourth pharyngeal pouches will cause thymic hypoplasia. You later give rise to the thymus. So if there is a poor development of the third and the fourth pharyngeal pouches. The thymus will not develop, the parathyroid and some clear cells of the thyroid is here, thymus is here, will not develop. And if you then the development of the T cell, patient have variable loss of T cell mediated immunity. T cells is depleted, and because the thymus is needed for T cell maturation, and congenital defect of the heart and usually combines with heart and blood vessels deficiency. So patient will present with poor defense against certain fungal and viral infection due to absence of cell mediated immunity. If the T cells is deficient, there will be no cell mediated immunity. And most of the time is the fungal and virus that are not bacteria. Bacteria is more of antibody and phagocytes, the granulocytes. But for T cell, usually uh, viruses and fungi. Okay, so immunoglobulin levels may be normal because B cells is normal, plasma cells is normal. There is no mutation of the tyrosine kinase. B cells can develop into plasma cells can develop into immunoglobulins. So but it's just the thymic hypoplasia where the maturation of the T cells takes place that will be affected. So it's usually fungal and viruses that are results from deletion of the gene that maps the chromosome 22 Q11 seen in 90% of cases. So that is usually the cause of the. So there is this one again, there is a disease called Aldrich syndrome. It's also S-linked to recessive disease characterized by thrombocytopenia, eczema, and marked vulnerability to recurrent infection. The thymus is developed and is morphologically normal in the early phase of the illness, but there is a progressive secondary depletion of the T lymphocytes in the peripheral blood and the T cell zones of the lymph nodes. The thyroid is normal, so it's more of a peripheral disorder. And lymph nodes are also important in the maturation of the T cells. So with variable loss of cellular immunity. So this is called Aldrich syndrome. It's S-linked, so it will be seen mostly in males, where the gene encoding with called Aldrich syndrome protein is located, and that is where the problem comes from. The only treatment is BMT, bone marrow transplant. You also have the severe combined immunodeficiency. You have the B and the T together being deficient. So those patients are bombarded with bacteria, fungal, and viral infections, and then most of them will die before 6 months or immediately after 6 months when the maternally acquired antibody are depleted. So they die the first year of life without bone marrow transplants. Okay, so you have the severe form. Most common form accounting for 50 to 60% of this is the S-linked, which is also seen in male. There is also the rare classic forms, which is autosomal recessive of the severe combined immunodeficiency. The most common cause of autosomal recessive severe combined immunodeficiency is the enzyme deficiency of enzyme adenosine deaminase. So the mainstay of treatment is bone marrow transplant. Okay. So we talk about acquired. Those are the inherited, the S-linked gamma globulinemia, the common variable immunodeficiency, and then the isolated IgA at the B. For the T, you have the Digeorgis syndrome, you have the Wiskott-Aldrich syndrome, you have the severe combined immunodeficiency for B and T. So those are the inherited. So, but the acquired, you mentioned that could be infection like HIV/AIDS, and then chemotherapy, could be radiotherapy, because aging can also cause breast immunity. Okay, so malnutrition too, like in Gaza, what is taking place in Gaza, they are not eating for months, so they are severely malnourished, Adults can still cope, but children, and that's why they are dying like chickens, because some of them have not may not eat 2 days, 3 days, 4 days. So we'll talk about HIV because that's what you are going to come across in your practice. HIV is a virus that causes acquired immunodeficiency syndrome, and that is what is known as AIDS. So the HIV virus is RNA virus. It's RNA virus, RNA virus. So they are known as retroviruses because they have enzymes that can make them move from RNA into DNA. They have enzymes in them that can make them move from RNA into DNA. They need to be DNA for them to integrate into human cell, because so they usually use their enzyme, the they use a reverse transcriptase enzyme that they have. Once they infect the cell, they will deploy their reverse transcriptase enzyme to convert their RNA structure into HIV DNA. There is the HIV DNA that can now integrate into the nucleus of the host. They also have an enzyme called integrase that is used for this integration. So they now take over the replicative machinery of the host. You use your cell to produce HIV virus, and then they will now do replication. And as you are to have a normal replication, then is the HIV virus you are replicating. Then you have a transcription back into RNA, messenger RNA, and then from the transcription, you now have a translation into HIV protein, and then you now be manufacturing HIV virus once you are infected. And the HIV itself will know, once you have manufactured, once you have produced it yourself, then you can now imagine the billions and trillions of cells in your body that be, and that's why on daily basis you can produce up to 20 billion HIV virus on daily basis if there is no intervention. And the implication is that they will penetrate the cell through the helper T cell, through the CD4 cells. And as they are penetrating the cells, they are destroying the CD4 cells. And if they are destroying the CD4 cells, then the CD4 cells functions will be defective. And you know the function of the CD4, they help with the antigen presenting cells, they help with the antibodies, and intermediary between the T cells, CD8, and then the antibody. So, and that is why it is not the HIV itself that kills. So once they destroy your CD4 cells, you are now exposed to a lot of other opportunistic infections that ordinarily, if you are not infected with HIV, your body will be able to overcome. Okay, so that is the mechanism. We just go. So HIV virus has three genes: the GAG, the hole, and the envelope. The GAG encodes the viral protein P53-55, which is cleaved into P24 and P17. Okay, so you know about the window period. The window period is from when you get infected with HIV, the time before infection, and when the test can be positive. You do HIV test. So that's the window period. Usually, the rapid kit test that is used, window period can be up to 3 months to 6 months. Okay, so meaning that if you get infected today and then you donate your blood within 3 months, and then before 3 months you go for the test, it will still be negative, whereas you are incubating HIV, okay, so that the recipient of the blood will now develop HIV after transfusion. Similarly, if you make love, even before 3 months you are infected, you can transfer, you can infect your partner with HIV. But with this, it is now known that P24 antigen can be secreted. It's usually secreted after infection before the 3 months. So they now add P24 antigen to some kits, ELISA kits, and that's the fourth generation ELISA, to reduce the window period to like 4 weeks, 4 weeks to 6 weeks. So, because if you don't have P24 antigen, antibody to P24, it will not be positive. So that's the fourth generation ELISA. So that's the importance of this P24 antigen. Okay, then also don't forget the pole gene also will produce reverse transcriptase, integrase, and polymerase, which is not here. Reverse transcriptase, these are the enzymes used. I've told you that the reverse transcriptase of the HIV will be needed to convert the HIV RNA into the HIV DNA, because without the DNA, the HIV virus cannot integrate itself into the nucleus of the host. So it is the integrase that is needed, that is produced by this gene polymerase. You also have the envelope. The envelope gene is called envelope because it's needed for penetration. It's needed for penetration of the HIV virus into the cell. Okay, so it's clipped into glycoprotein 120 and glycoprotein 41. So in addition to all the genes, the GAG, the pole, and the envelope, you also have 6 other genes, the GAG, pole, and the, you have for HIV1. So these additional genes are the TAT, the REF, VI, and the VPR and VPU. Okay, they are also useful for the HIV virus. So the difference between HIV1 and there is HIV2. Okay, but the difference between HIV1 and HIV is just this VPS. The HIV2 carries VPS in place of the VPU in HIV1. They also have different functions that are, you may not bother yourself to know. Okay. So this is genetic structure of HIV. This is 3' long terminal repeats. That's the 5' long terminal repeats. And these are the ancestry genes. And then you have the main genes, the GAG, the pole, and then there is envelope somewhere. Okay, this is the envelope. So this is the envelope. The pole will secrete reverse transcriptase, integrase, and polymerase protease. Then the GAG will secrete P24 and 17, and the envelope will secrete oblin. So, like I said, uninhibited viral replication results in production of about 10 billion. If you are infected today, so every day your body will produce 10 billion HIV virus. So viral turnover is very rapid, and then those 10 billion will now be infecting your CD4 cells and be damaging it. Okay, so replacement of about 50% of the viral pool, and every day. So this is the summary of the infection. If you are infected with HIV, it goes into your cell, and then the HIV RNA to converted to HIV DNA. HIV DNA with what? Reverse transcriptase. HIV DNA is integrated into your nucleus with the integrase, and then replication will take place, and then transcription will produce HIV RNA, and the transcription messenger RNA is HIV RNA messenger RNA and not your messenger RNA. And then the translation will now be HIV itself. So it will now be producing, and it will assemble itself with the enzyme protease. and then it will be released, it will burn off. So every day if you are infected with HIV, you will be producing 10 billion HIV virus, and that's the structure how it looks. So mutation, and you know the challenge is that, and that's why they've not been able to get they've not been able to get the drugs, as they are replicating, they're translating, they are doing transcription, they are mutating, so that if you use a particular drug today, mutation will not make it work again after some time. So that is the challenge. Mutation occurs under routine replication condition, partly because many of the enzymatic process in HIV life cycle do not include corrective mechanisms. Okay, so mutation may also occur when selective pressure is exerted, such as when the host is suboptimally adherent to the HIV drugs. So HIV turns the replicative machinery of the host cells to its advantage. It will now use the host cell to produce HIV. So these are the stages of HIV. So there is the envelope gene no split into 120 and 41. So 120 binds to the CD4 cells on the surface. There is a conformational change occurring after the binding, so exposing the 41 of the envelope. So the glycoprotein interacts with chemokine co-receptors CCR5 and CSCR4. These are chemokine receptors that have been identified to be responsible for serodiscordant couples. So serodiscordant, the husband is positive, wife is negative, wife is positive, husband is negative. Those are the serodiscordants, and they are making love with each other, and they keep their status as they are, because you need this glycoprotein CCR5 and CSAR4 for penetration of the HIV virus. So if you are genetically deficient in CCR5 or CSCR4, if you are bathing with HIV blood, you are sleeping with HIV infected, then the HIV will not be able to penetrate your cell. So it is also needed. So they are trying to genetically engineer this glycoprotein to prevent entry, HIV entry. So and that's one of the reasons. So you have some drugs that can inhibit these drugs. This that does inhibit it. Inhibit it because person is infected of HIV already, but it's going to prevent further cell damage. So you have, not that it's going to prevent entry. If you have been taking it before before you are infected, it's a different ballgame. But the person is infected, HIV itself is integrated already into the nucleus, and is making use of the DNA of the host already. But the one forms may not be able to penetrate other cells if you use medication that can inhibit this. So there is a fusion reaction between the lipid bilayer of the virus, and that's the glycoprotein 441 and the host. So glycoprotein 41 binds to the CD4, and then through the glycoprotein CCR5 and CSCR4 penetrates the cell. So it cannot penetrate without those glycoprotein. So you can see the diagram. HIV1 binds to the glycoprotein through the glycoprotein 41, binds the CD4, needs the CD4, but it also needs this CCR5 and CSCR4 to penetrate the cells. Okay, it needs this glycoprotein. So if you are heterozygous deficient, that you have inherited one from your father but not from your mother, then you are considered as long-term non-progressors. It will slow down the entry, so you may not have symptoms. So long-term non-progressors are those who are HIV positive and are asymptomatic for at least 10 years of infection. If you are 10 years and you don't break down with any infection, any symptoms, and then you've been positive for long, so it could be that you are heterozygous deficient. But if you are homozygous deficient, you have not, so cannot be infected, cannot be infected. So I've described what happens. It enters the cells, on coat itself, P24 is released, and then the RNA HIV converted to DNA, DNA is integrated into the host, and that's what happens here. So after entering the cell, P24 antigen is released, and that's why it is used to is to release the acute infection of HIV, and that's what has been used to bring down the window period to like 4 weeks to 6 weeks with ELISA. So it has been synthesized and can be attached to a well. So if they add your antibody, if you add your blood to it, you have antibody to P24, and you have color developer, it will show as you have P24. And you should not have P24 if you have not been infected with HIV. Okay, so they've used that to bring down the window period from 3 months to like 4 weeks to 6 weeks. So reverse transcriptase enzyme is deployed and converts, once the P24 uncoats, is just removing the dress of HIV, removes its stress, and then the enzymes, reverse transcriptase, will come into play and say, okay, you cannot penetrate this cell if you are still RNA. Convert the RNA into DNA. So it uses the reverse transcriptase to convert the viral RNA into double-stranded DNA. And then it now moves, this is the cytoplasm, it now moves towards the nucleus. Okay? It moves towards the nucleus, and then it gets integrated into the nucleus. And then I've described what happens. It uses the host DNA to produce HIV, then replication, transcription, translation, and the assembly of the HIV produced, and then bursts out. And then as it's budding out, it's killing the cells. It's killing the cells. So this is successful integration, means that the host CL. So if you are infected with HIV, if you can truncate the integration takes 72 hours, then you are good. That's if you are exposed, you are on the ward, you are drawing blood, you are setting line, put up drip to HIV patients, and then you prick yourself. You prick yourself. So if you can start the treatment of HIV within 72 hours, then you are going to block the integration of the HIV virus into your DNA. But if you don't do that within 72 hours, once the HIV gets integrated into your DNA, that's the end of the road. That's why if you are exposed to HIV on the ward or sexually transmitted infection and you are sure, then you must start treatment immediately. You must start it so as to block the integration of the HIV. So viral DNA is referred to as provirus once it's integrated. Once it's integrated, you can see it's moving in with an integrase, and then this is the host DNA. Okay, and then it's going to replace the host DNA with HIV DNA that is produced. Okay, so that's what happens. And then transcription takes place, and then translation takes place, and then you have budding, and so budding will release the HIV virus, and each virus will now go after each cell again, and then penetrate the CD4 again, and then destroy the CD4. And that's why the CD4 always drops. after infection, and then the viral load will be high, millions, goes into millions. But once you start treatment, the CD4 is expected to rise, and then the viral load is expected to drop if the drug is working well. So thank you for listening. So